Welcome back, everyone. My name is Marj Matchee.
And I'm Kentrina Jenkins.
And this is We Got Your Six. So we are thrilled to bring back Dr. Zukiwski. We promised that we'd have a second conversation or carry on our conversation. It's a huge topic and it takes some time to cover it. And we want to thank you first, Dr. Zukiwski, for bringing your expertise back to the table and allowing us this time with you. And I'm just going to let you kind of pick up where we left off. You're going to talk a little bit about the treatment side of things, as opposed we spoke about the brain mapping and neurofeedback, and you showed us some examples and things. So people who haven't seen that episode, if you want, you just have to go back to We Got Your Six Facebook page or the YouTube channel, and you will find this particular episode, and then you can follow up with this one. So welcome back, Dr. Zukiwski. We're just really grateful to have you back.
Great. Well, thank you for having me back, and thanks for the opportunity to do the first interview on brain assessments and brain mapping, and also event-related potentials. So I think we covered a lot of good information there, and now we can talk about what we use that information for.
Great.
Okay.
Perfect.
So just to introduce myself very briefly, my name is Dr. Zukiwski. I'm a psychologist in private practice in Edmonton, Alberta. My background is counseling psychology, but I have training in clinical psychology. And the difference is as a functioning basis as a clinical psychologist, I do both assessments and diagnosis and treatment. So we talked about using interviews, questionnaires, and brain mapping to do assessments and try and find out, I use the word targets, what parts of the brain we want to treat in order to help reduce symptoms and treat different disorders that people come in with, whether it be PTSD, brain injuries, depression, anxiety, range of symptoms. So today I'd like to talk about just what some of the treatment options are. And I'm not going to talk about counseling treatments. I'm going to talk about other treatments. There's many different psychotherapies. My specialty area is more under the umbrella of a term called biofeedback. And also other terms that you may have heard of are neurofeedback. And I'm going to talk about a new term that many people may not have heard of, which is called neuromodulation, and the types of treatments under that. I'm not really going to be commenting too much specifically about what I do, because I think there's many different types of treatments that are very good. No one can really do all the treatments, and many people will specialize and become very experienced at doing, let's say, one type of treatment. And it all depends on how you use that tool, how experienced you are, and what information you have to guide the treatment. And so, even what might be considered a simple or old type brain biofeedback treatment could still be very effective in the hands of someone who knows how to use it with good information to how to target the brain.
Well, that makes sense.
Okay.
Absolutely.
So in terms of treatments, let's talk about the term, let's say, biofeedback, which has become also to be known as neurofeedback. But biofeedback is an umbrella term that's, I would call it an umbrella term that has a lot of things under it. And basically what biofeedback is, it's the use of some sort of sensor that's placed on the body to monitor some part of your physiology. That could be your pulse rate, your hand temperature, or it could be the electrical activity in your brain. So what you do first is you measure something that you can't feel. You can't normally feel those things, and in order to use the body's ability to learn to self-regulate, that's one of the terms that's used in biofeedback, so you can learn to change what's going on in your body, that's to regulate it or change it, we need to measure it. Something like, let's say, muscle tension, you might be able to feel that part's tense and you can let it go. And so that's a form of your own biofeedback, that you can feel it However, let's say if you had muscle tension, that your muscles are so used to becoming very tense and firing all the time, you might feel that muscle's relaxed, but it's actually firing and producing a lot of electrical activity. So if we put a sensor on that muscle where we can actually feel the electrical or measure the electrical activity, and then we will use a computer to display that information. So early biofeedback equipment might have actually just been a standalone machine with a dial on it, maybe just a needle that would move to the left or the right, and that could be temperature, for example, hand temperature warming, or it could be a muscle tension, and it could just be a tone that would change. So we need to provide some sort of feedback to the person. That can be through visual information, such as a dial or bar, or maybe even now a movie that's playing. Sound, so you may have tones, beeps, or sound from a movie. And you can even have devices that produce, let's say, vibrations. Let's say for kids, you might have a stuffed animal that has a speaker in it, and they may actually be able to feel the rumbling of that stuffed animal, purring when they're getting positive feedback. So however we get that sensory information into the person, we're going to tell the person what we want to have happen, and then we provide feedback when it does happen. And that will teach them both in some cases, to learn how to control and regulate their body, such as learn to relax muscles. But some things you can't feel, and it's more of what's called learning through reward or operant conditioning. And you're just receiving positive feedback and reward to tell you that what we want to have happen is occurring more. And then as we do that over and over, you're actually going to teach the person to learn how to relax, for example, or teach the brain or body to change in different ways. So that's the really basic overview process of biofeedback. So you place a sensor on what you want to measure. You measure it. You tell the person, do you want that value to increase or decrease? And it could go either way. And you pat them on the back and say, good job when it happens. So there's some social reward, and you provide some sort of auditory visual feedback to help teach their brain that it's going in the correct direction.
Nice.
That's a quick little overview. I can talk a little bit more about some of the different types of biofeedback and neurofeedback. Any questions or comments so far?
I just simplifying the heck out of it in my brain, but when you're talking about biofeedback and putting a sensor on and getting something back, I think of nurses with the blood pressure thing on your finger, or taking your, all those things they come and do to you. That's a biofeedback. And then it's much like Pavlov's dogs. You're training your brain, right? So
there's probably some of what might be called classical conditioning, where you're providing a reward and it's happening at the same time. But also what's called operant conditioning, and you're using rewards to teach the brain to change. And there is some biofeedback that it's the person is learning a state, like for example, learning how to relax, and they're getting feedback when they learn to relax and they learn to control it. But there's other things like, for example, change in the brain. Sometimes the person may be able to learn, to change maybe an arousal or awakeness or a change in attention, but other times it's something that they will probably never be able to feel the difference, but through the feedback, you can change amazingly small changes in brain activity, different frequencies, and at precise locations in the brain. It's really amazing how quickly the brain can learn. And often, even in the first session, you can see the person starting to be able to have some changes as a result of the reward.
you took the question right out of my mouth. I was going to ask you how quickly one would see that change.
It all depends on the person,
Right.
what you're measuring. Sometimes they might start having changes and get some control in the first session. Sometimes it might take a few sessions to practice, but usually remarkably quickly.
And that
That doesn't mean you might get clinical effects, Sometimes you might start seeing some clinical effects even in the first session, but it might take several sessions before you start noticing some changes in mood or something like that.
I think it's still exciting, like just to think, because there was such a long time that I thought one of the main therapies was only like talk therapy, right? So it's like, and you think, like, yes, there's benefits to talk therapy and stuff, but when you think of the possibilities that you can have when when you add talk therapy with any of the other like helpful treatments, and then adding this stuff in here, knowing that there's a measurable a measurable improvement is exciting, really.
You made an excellent point that the biofeedback or brain biofeedback, called neurofeedback, does not necessarily have to be standalone. It can be combined with psychotherapy. Either you could do some talk therapy in the same session and also still have time to do some neurofeedback. That's very common, depending on what the veteran or civilian needs that day. But also, I've had reports from other therapists who are providing, let's say, psychotherapy with the person long term, and then that client starts doing a brain biofeedback. Then the therapist reports that this person is starting to improve in their counseling much more rapidly. So their mood regulation is better. They're better able to talk about certain topics without becoming overwhelmed. They're able to learn skills that are being taught, let's say, by a social worker or coping skills by their psychologist. And so it's possible that the treatments can actually improve the effectiveness of counseling that happens at the same time. I don't know if there's any research on that, but I've certainly heard that being reported. Mm-hmm. And the neuromodulation treatment that I'm going to talk about later is believed to actually make the brain more plastic, which means that it can actually make the brain more amenable to permanent neurological change. And so if you do any type of psychotherapy within a short window around the time that you're doing the neurofeedback, the brain stimulation, it could be at the same time, then that may even make the therapy more effective. That's speculation, but they are looking at doing neurostimulation treatments at the same time, for example, or just before people do physical therapy to make the physical therapy more effective. So I think there's a lot of really exciting changes that are happening in this field.
Absolutely. So, such a big improvement compared to hearing like, oh, that's just PTSD, or, that's just, whatever diagnosis it is. And then instead hearing, like that there's more changes and more options and that different things are going to work for different people. It's really exciting.
Yeah. Mm-hmm. So I might talk more about, if there's time, biofeedback treatments at the end, which would be more towards stress management, which I think could be very valuable. But I'm going to focus on the area that I'm most excited about and spend most of my time, which is the neurofeedback. So we can talk about brain biofeedback first and then neuromodulation. And I think that's really the area of excitement and probably the most area of interest, particularly the people who are dealing with quinism, methylquin toxicity related symptoms, which is essentially a type of brain injury. So we need to target the brain to fix that or to help decrease symptoms, I should say. So let's talk about neurofeedback. So I'm not going to talk about every type of neurofeedback. There's many different types, but neurofeedback typically refers to biofeedback of electrical activity in the brain. So just like when we do a brain map and we put electrodes on the scalp to measure electrical activity, we can have similar devices that measure electrical activity to provide biofeedback. So the setups can widely vary. There's a lot of different equipment manufacturers, we call them vendors, and many of them create their own, unique devices and unique protocols, and then people will try them out, learn them, and then apply them to their clients. often experimentally at the beginning, and then do clinical research to see how effective they are. All right, so first I'd like to talk about neurofeedback. There's a lot of different types of neurofeedback. The most well-known type, of which there's many different subcategories, is biofeedback of electrical activity. So typically if you'll search the term neurofeedback, that's what it's referring to. There are other types, but let's focus on biofeedback of electrical activity, which will include terms that you may have heard, such as Loretta neurofeedback. So the part of the difference is how many channels that the person's monitoring and providing feedback on. So the early neurofeedback, which can be very effective, was developed as just a single channel neurofeedback. And if you have the location of the brain that you want to target, and it's one site or two sites, it may be very effective and very appropriate to use this very early version, which monitors just one location or two locations. So basically, the way that would be set up for a one-channel neurofeedback is you'd have an active electrode where you'd place on the head that you want to monitor, and then you have two other electrodes. One is a ground and the other one is the electrical reference. So it's always this site has to be compared to something. So if we just want to monitor this site, you can have the other electrodes in the air. One's an electrical ground and the other one is considered to be relatively neutral. So you're considered to be mostly monitoring this site. However, sometimes you may actually want to have the comparison on the brain, and there's different reasons to do that. So you might put both electrodes on the head, and so that actually can allow you to target the difference between those sites. And depending on your protocol, it's possible that both sites may change beneficially. So that would be a very simple hookup. Usually what will happen is the neurofeedback, the therapist will have software that will measure and monitor frequencies, usually from 1 hertz, and hertz is the number of pulses per second, to 30 hertz. There is some neurofeedback that works in higher frequencies, but usually it's about 1 to 30 hertz. So then we have the different frequency ranges that we talked about in the last video. And usually you'll be setting the computer software to provide feedback when there's changes in the different frequencies. So for example, there's the slow frequencies, delta and theta, from 1 to 4 and 4 to 7. Usually the software will be set to provide a reward when those frequencies are going down. That's often the case. Alpha, which is from 8 to 12 hertz, depending on the type of biofeedback or neurofeedback, sometimes you might want to train that up. So when that value of the alpha increases and the brain is relaxing, usually that would be with eyes closed, then you'll get that feedback. You might hear the machine beeping or the bar going up above a goal line. So you might actually see a bar with a little bar across it, and when your value goes up, it looks like a thermometer bar, and it'll go over that value, which is your goal line, and then you'll get the reward. So that goal line is the threshold. When you're below it, you don't get the reward, and if you want it to increase, as you go up above that goal line, beep, 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 beep. It goes below, no beeps. Goes up again, beep, 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 or a tone or a movie playing. So you get that feedback when it changes. Sometimes the person may have too much alpha waves, so you do it exactly the opposite way. You set the computer to provide the feedback when the value goes down. Okay. So when you set the goal line at a certain level of microvolts, and when that let's say if they have maybe 20 microvolts of alpha and it's way too much, and you want to have it decrease, maybe your goal line might be set at 15 or 10 microvolts. So when they're in their normal range, they don't get any feedback.
Right.
But when the alpha waves start going down, beep, 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 beep. So it'll get some feedback. Like I said, that the feedback could be many different things. It could be a video game, it could be a movie, or just simply hearing a tone. Or you could just have a bar and the person's looking at the bar, and whenever it goes down, they know that their brain is doing the right thing, and you're patting them on the back, and their brain will learn to keep that value below the goal line.
That's so interesting.
And then there's the beta frequencies, and then sometimes you might increase a healthy beta frequency, and there's different treatments that you may do that for. It's usually the higher beta frequencies, which are more associated with anxiety. Usually those frequencies are inhibited or pushed down. So it's very common to have a setup on the biofeedback software to actually target 1, 2, or 3 different frequency ranges. So slow waves have to go down. That's maybe daydreaming, sleepy slow waves, lack of concentration. Those have to go down. Maybe the alpha waves have to go down. Your brain has to come out of an idle state. And a healthy beta has to go up when your brain is more awake and thinking. But the fast beta waves, which may be more associated with anxiety, those have to stay down. So you might have to meet all those criteria in order for the machine to provide the feedback. That's a very simple, basic EEG biofeedback.
Great explanation.
What a great way to hear about it too. And then, because it's nice to hear the science behind it. Mm-hmm. And then because people will say like, oh, I have too much anxiety, or, I'm consistently feeling way too far down, right? Like with mood and just kind of like on the couch, right? So it's nice to hear that those things can be adjusted, right? Like rather than just throwing a positive quote at someone and being like, oh, just be more upbeat and just do that. So it's nice to know that there's a treatment and there's a way to help alleviate these things.
Yes.
And you're actually making the brain satisfied. So when it's satisfied, it learns the behavior, and it's really interesting.
Yeah. When you're providing the feedback, it's learning to make that occur more often. And when the brain practices that positive change over and over, there's those neurons, when it's kind of an adage in neurology, when those neurons fire together, they wire together. So when you practice that change, the brain actually can make neuroplastic changes where that change can become permanent. So you can have changes in neuronal growth, new inhibitory patterns in the brain, changes in vascular growth, things like this. So you can have permanent structural and functional changes in the brain as a result. Now, a big issue is how do you know how to do those settings? Which ones to push up, which ones to push down? That's a key part of the clinical practice, is making your decisions of the settings, and then how hard to set those goal lines. If they're too easy and the person receives too much feedback, their brain may not learn. If you make the goal too difficult and they don't receive enough feedback, then their brain often won't learn and they may become frustrated. So you have to learn how to either manually set the goal lines, or else the computer may be able to do some called automatic thresholding. So it may set the goal lines for you automatically, and it may adjust those goal lines as the person's brain is changing. Those goal lines will change as well, and to continue challenging the person. So the protocols can come from different places. There are fairly well-researched protocols. Some have a lot of research, some have less research, and people may use certain treatments, and there's actually terms for some of them. And they'll say, okay, well, you have PTSD, we're going to do a treatment called alpha theta. So alpha theta training is basically when you have the person, usually it's with your eyes closed, and you have them increase relaxation waves in their brain, which is alpha, which is an idling frequency. You reward that, and then you reward their brain as it shifts into more of a pre-sleep daydreamy state, which is when the theta waves go up. And so you're going to reward this shift in brain state to more of a pre-sleep dreamy state. And this is thought to potentially help with processing of memories, things like that, for treatment of PTSD, for example, and teaching the person's brain to relax. So that would be a type of therapy that may or may not be guided by a brain map. So there's some people who do neurofeedback that don't do brain maps, and
Right.
they are using protocols and they're really using maybe an educated guess, or just saying we're going to use the same protocol for treating this disorder. Now, if you don't have a brain map, you really don't know for sure if the person actually would maybe benefit from increasing or decreasing those frequencies. Maybe it's exactly the opposite of what they need. So they're making some guesswork in that case. But there's people who do that. So it's important, if you're seeking out a neurofeedback practitioner, find out how they're making those protocols, and are they using brain maps to guide them. However, sometimes it is maybe appropriate to use these research protocols such as alpha theta, or another one is called SMR training. This may be used for treatment of attention deficit disorder, seizures, and also for calming down the emotional system. So on this part of the brain right across the top, there's a certain frequency that kind of stabilizes the brain against seizures and calms down the emotional frequency, and that's a low beta frequency. And so that's a quite well-researched protocol that's often used in treatment, like I said, of seizures and ADHD. And so the person might use that protocol if they don't have a brain map. However, a brain map is really important, because sometimes a person has way too much of that frequency, and that would not be a good thing, to likely to increase that frequency, just presuming that they need it, and it's actually the exact opposite of what they need. So if you're seeking out therapy, if you can, get a brain map first, but it's not 100% required.
I just can't help but think that because we're still new in figuring out what really is happening with the brain injury from mefloquine, that mapping is just kind of essential to me in a way. I think it makes it a much more effective treatment for sure for someone who's already been through the gamut of everything. I think that, it just goes without saying to me that I think if you could get the mapping done, I've seen it done. I've seen how you, in 3 hours, or I think it was just about 4 hours, you were able to say, okay, this is what we need to look at. This is the areas we need to target.
Yes. And even in the short time that I've been doing the more advanced type of brain mapping called event-related potentials, there are certain brain function abnormalities that I'm finding that a number of the different veterans have, but then I'm finding differences between them as well. So it's possible that there might be subgroups that certain portion of them have this certain pattern, other ones will have this pattern, but ultimately each person's protocol is different and can be customized to exactly what they need. So having the brain map before, and doing if possible, the most advanced analysis possible. Get as much information as you can.
Absolutely, I agree totally.
So as we any more questions, I'll just talk about a little bit more about the different multi-channel neurofeedback.
No, go ahead.
That's perfect. Yeah.
Okay, so increasing the number of channels. There's 2-channel neurofeedback, which can be used to target 2 different places on the brain, or target something called coherence, which it's not completely accurate, but it can be considered to be how the different parts of the brain are communicating with each other, and how similarly they're operating. So if you might have 2 areas that are too similar and they're kind of in lockstep together, you can use what's called coherence training to train that part of the brain those 2 parts of the brain to function more independently. So that's something that you need at least 2 channels for. There's also 4-channel neurofeedback. And then above 4, usually a person would actually go to using a full cap, which is a full 19 electrodes. And so then you're gathering a lot of data at many sites in the brain. And then that opens up the possibility of doing some other different types of feedback. Now, the neurofeedback that I talked about first is where the clinician is deciding on what frequencies to go up or down and what the goal line should be. Okay, that's based on their clinical experience and what the information they have. There is also another type of neurofeedback that is that's also that's needed for neurofeedback, and this is called Z-score neurofeedback. So this is where you're measuring usually all the electrodes on the head. However, it could be a smaller number. And then in real time, the computer is comparing what's being recorded to a database of what's normal. And these databases are used in the brain mapping. You compare that individual against what's considered to be normal and well functioning. So in real time, that person's electrical activity is compared to the normative database, and then the computer makes decisions of setting the goal lines with the purpose of always kind of pushing the person, nudging them towards what's considered to be normal. And this is called Z-score, and this can be done for, like I said, for the full brain cap, and it can be done for what would be called surface training, where you're measuring the surface electrical activity and you're training that back to normal. And the therapist may usually choose which locations that they're targeting, or they potentially could try and target all of them at once. And then there's what's called Loretta neurofeedback. So Loretta is basically you're using high-level math in the computer to try and triangulate where within this sphere, where the generators of the electrical activity are coming from. So maybe that excess brainwave that's causing the problem might be coming from the surface, the cortical part of the brain, or it could be coming from a deeper structure. So maybe more in the back center or the front center. And so the Loretta neurofeedback will use this three-dimensional targeting, and the person will set the software to potentially target one location deeper in the brain. So that's Loretta, which is this three-dimensional trying to locate parts of the brain that are not functioning right and try and get them to change by providing that computerized automated feedback. I've certainly heard different comments from people in the neurofeedback field. Some people, swear by the Loretta neurofeedback, and other people, are a little bit more skeptical because everyone has their own different treatments that they like and they're experienced with. So, I think they all have potential. It depends how you use them.
Absolutely.
And of course, there's all sorts of different skill levels too. There's the Z-score neurofeedback, which is where you're pushing the person towards normal. That could be used by someone who has a lot less experience, and they just let the computer make all the decisions. And they may pick a region of the brain based on a brain map or not. However, it could also be used by someone who is extremely experienced in that type of neurofeedback, and maybe they even be able to work on how the different networks in the brain and how they communicate with each other. So as always, the whole range of experience, everyone has to start from somewhere. So you can have someone who's very new and experienced, or someone who has a lot of experience, and that could be either with the simple types of neurofeedback or with the more cutting edge multi-channel neurofeedback. But you can do good work with all of them.
That is extremely exciting and extremely hopeful. Like when the more I'm always afraid when I hear things that are, just like this one, stuck in a box.
Yeah.
Right.
One size fits all.
Yeah. So hearing that there's like so many different ways, and that, even people that are, experienced or less experienced, that they'll try like the different ways, right? It's not like you move up to this. It's all over the place, and it's to me, I just find it beautiful. So I think it brings so much hope for treatment.
All right, so I'd also like to talk about neuromodulation treatment. So I think you could refer to the neuromodulation or neurostimulation treatments. So these are not biofeedback. This is a very cutting edge area. There's a lot of research going into brain stimulation treatments for a wide range of conditions. Probably the most researched is in depression. And so basically what we're doing is we're using different types of technology to basically stimulate or push the brain to change. Probably the most widely used one right now is called transcranial electric stimulation, or transcranial direct current stimulation. Then there's different types. So basically what you're doing is you're using a very, very low level electrical current, about 1 or 2 milliamps, and only about 10% of that current actually reaches the brain. So it's a very, very low level. It's so level it actually doesn't cause the neurons to fire, but what it does is it changes the threshold of how those neurons fire. So let's say if you have a brain map and you have an area, the part that the brain is weak, and you can place a positive electrode on or anode on that part of the brain and provide a very low amount of electrical activity into that site. And what it does is it changes, I use the analogy for veterans, if it changes like as on the poundage on a trigger, it changes let's say a 12-pound trigger, which is more difficult to fire. It lowers the firing threshold. So maybe that becomes a 4-pound trigger. So it's very easy for those neurons to get together and fire and basically help energize and wake up that area. That's a really oversimplification. But this is, I think, a very powerful way and safe way of activating and waking up areas of the brain that are weak. And you can also place the negative electrode, the cathode, on parts of the brain that are overactive. And this has a lot of potential, especially for treating anxiety and obsessive compulsive symptoms, which can be sometimes extremely difficult to treat. And you may find part of the brain that's running very fast and overactive, and that may be very difficult to train down sometimes with neurofeedback. You can place a negative electrode over that area and get it to calm down. And it's possible to do more than one side of the brain at the time. For example, you could treat the left frontal area to help wake it up as a well-established treatment for depression. And you could also place a negative electrode, let's say on the back of the head here, which is overactive, and that's associated with anxiety and obsessive thoughts, and sometimes with PTSD. So this is a safe, a non-invasive brain stimulation or neuromodulation treatment that actually can be done at the same time as you're doing talk therapy too. So this is one type of neuromodulation treatment that has a lot of potential. There's also other types, transcranial alternating current, where you're actually injecting frequencies into areas that are missing or have low frequency values. So you can help train that part of the brain to produce the right frequency. You can use random noise, which is not noise, but it's randomly produced electrical activity to help energize and wake up an area. So there's many different types of this electrical stimulation. There's also transcranial magnetic stimulation, which is usually more done by psychiatrists. It's very high power magnets, and for example, they'll be placed over this part of the brain and pulsed to induce neuronal activity. Low power magnetic stimulation is called pulsed electromagnetic frequency. This does not cause neurons to fire. This can be used to decrease inflammation. And when Dave Bono was talking about putting magnets on the base of his skull, that's PEMF, pulsed electromagnetic frequency. So you could use that to decrease inflammation, to also possibly to help teach those parts of the brain to produce frequencies by injecting frequencies with that very safe magnet. So basically you're inducing electrical activity into the brain as that magnet turns on and off at whatever frequency you set it for. So there's electrical stimulation, there's magnetic stimulation, and a really exciting area is called photobiomodulation, where you're actually using infrared light of certain frequencies, either pulsed or not pulsed, and those frequencies will pass right through the bone and the skull as if it almost doesn't exist. It goes right through instantly. And so you can put light energy into an area of the brain that's weak. And there's research going on into possible treatment of Alzheimer's, for example, that there's a certain frequency that might break down plaques in Alzheimer's. So
Wow.
very quick overview. I can maybe talk about these in more detail someday, but the neuromodulation therapies I think are really exciting and open up a lot of potential to change how the brain's working safely.
In regards to like this episode, what would you think would be, the biggest message of hope?
I think that there's a lot of new technology that is being developed. There's a lot of research going on, particularly in the area of neuromodulation, which I haven't talked about. That I think has a lot of potential. And the neurofeedback community is more and more starting to embrace the non-biofeedback therapies or the neurostimulation, neuromodulation treatments. I think that's probably the area of growth, and is really the future of non-pharmaceutical treatments of psychological and psychiatric problems. That's where the future will lay. So I think there's a lot of hope.
Wow.
I can't wait to hear more.
Me too. It's so cutting edge and it's so exciting, and we have so much to learn. We can't thank you enough for bringing your expertise to the table again, and we appreciate so much the time you give us, and you are so welcome to come back. Should you think of anything that maybe there's something new with neuromodulation that we want to talk about, or some other ideas you have that you want to share at any time, we'd love to have you back.
Yeah, and I'm sure
Thank you very much for having me.
Absolutely. And I'm sure that there's many other treatments that are already out there now that you could share with us. It's so exciting. So I bet
just a brief overview. Thank you for having me. I'm honored to have the opportunity to share this information. And these treatments are good for a wide range of conditions, and I think they're very applicable for people suffering from quinism or mefloquine toxicity. We can measure the parts of the brain that are not working right. If their limbic system is overactive, their emotional system is overactive, if their front part of the brain is not working right, so they can't inhibit their anger and their actions, we can use these treatments to help improve their brain function, make a change, and get great reductions in their symptoms in most cases.
That's absolutely amazing.
Fantastic and very hopeful.
It is. And we just thank you so much. So, once again, we could just go on forever with you, and we just thank you again so much. So everyone who, if you want to go back and break this down, just watch our videos again with Dr. Zukiwski from start to finish, and it talks about everything. And we're just really honored to have you here, and come back again anytime. This has been this episode of We Got Your Six. Take care, everyone. Take care.
Thank you.
Bye. Thank you. Bye-bye.
Bye.